भवतु सह नो भुनक्तु सह वीर्यं कर्वावहै तेजस्विनावदितमस्तु मा विद्विषावहै ॐ शान्तिः शान्तिः शान्तिः. Dear students, today we are going to discuss on the fracture patella. You all know that patella is the largest sesamoid bone in the body. The clinical picture of the patellar fracture is determined by a combination of definite and equivocal signs. But before that, let us revise the functions of patella. 1. Patella increases the mechanical advantages of quadriceps tendon by increasing the efficiency of the extensor mechanism by as much as 50% due to the increased lever arm. Second, it aids in the nourishment of articular cartilage. Third, it protects the femoral condyle from the injury. And fourth, it acts as a hydraulic brake. So, coming to the fracture patella incidence. Incidence is around 1% of all skeletal fractures. Now you can see in this particular X-ray how the patella is fractured. Coming to the mechanism of injury, direct trauma. This is due to the dashboard injuries and due to the direct fall over the patella. Now they usually cause comminuted fractures and are the common causes. The subcutaneous location of the patella makes it more vulnerable for direct injuries. The second mechanism is the indirect trauma, that is quadriceps contraction, as what you are saying in this particular X-ray. The sudden forceful contraction of the quadriceps, as in the sports person or the athletes, can cause the patellar fractures. And here the fracture is usually transverse as shown in this particular X-ray, and sometimes avulsion fracture of the proximal or distal poles may also be seen. Age, common in 20 to 50 years of age group. Male to female ratio is 2:1. The fracture patella is classified into two broad categories: undisplaced fracture, displaced fracture. Now you can see in this particular picture, the first picture is an undisplaced fracture patella transverse, and the fourth picture is undisplaced. Remaining all are displaced fractures. Now the undisplaced fracture patella may be a transverse fracture or a stellate fracture as shown in the fourth picture, or it may be a vertical fracture as seen in the seventh picture, seventh part. The transverse fracture, this accounts for nearly 50 to 80% of the cases, and about 80% occurs in the middle third. Now the displaced fracture, if the displacement is more than 3 mm and if the articular incongruity is more than 2 mm, then we call it as a displaced fracture patella, and this can be of 6 different patterns. The displaced fracture patella, it may be one transverse involving upper or lower poles 50 to 85%. It could be oblique. It could be vertical fracture 12 to 27%. It could be comminuted fracture as you can see in the fifth picture here. Then it could be polar, proximal or distal, or it could be osteochondral fractures. Coming to the clinical features of fracture patella, the patient gives history of trauma, following which there is a pain, swelling, and bluish discoloration as you can see here at the knee joint. Patient is unable to extend the knee and both active and passive movements are restricted. On examination, there could be a palpable gap as seen in this particular picture. You can see the gap, the finger is put in the gap. There may be tenderness, signs of effusion, and a positive patellar tap. The investigation wise, the radiograph of the knee joint consists of the AP view, the lateral view, intercondylar notch view, and skyline axial view to rule out the undisplaced vertical fracture as shown in this second X-ray. CT scan, bone scan and tomography are other useful investigation. However, they are very rarely required. Bipartite patella and osteochondral fractures, they cause confusion in the diagnosis. Now you can see this to compare these two x-rays. The first x-ray is showing the fracture patella. The second x-ray, there is the bipartite patella. Do you know which patellar fractures are difficult to diagnose clinically? Well, it is the thin vertical fracture of the patella as shown in this particular picture, which has a very few clinical signs and symptoms. Management wise, in the undisplaced fracture, non-operative treatment will produce good results in undisplaced fractures, and if the displacement is less than 1 to 2 mm and there is an intact extensor mechanism and minimal articular step-off less than 1 to 2 mm. And the methods include the compression bandage, the ice application, aspiration of hemarthrosis, a cylindrical cast in extension, and or a long leg cast for 4 to 6 weeks. The functional cast brace, this is the functional cast brace here. So it is also effective. The management of undisplaced fracture continues. The patient is advised early weight bearing. The quadriceps exercises are to be advised. Coming to the management of a displaced fracture, in this variety, the surgery is the treatment of choice. Surgery is performed as early as possible, preferably within 7 days. Now, the methods include mainly the open reduction and patellectomy, open reduction internal fixation, and secondly, sometimes patellectomy. Now, the open reduction is indicated in the transverse fracture of the patella. The internal fixation is done either by the circumferential wiring, as shown in this particular X-ray, or by tension band wiring. The other methods of the pivot technique of circumferential wiring and a second tension band wiring through the tendon provides a better fixation. The load case longitudinal anterior band wiring is another method. This tension band wiring, this X-ray shows how the tension band wiring is done. This is another method with the good results. Now, the anterior tension band wiring through the though the popular methods of stabilization of mainly the transverse patellar fractures and K-wire offers the following problems. Now, as you can see here, there could be migration of the K-wire up and down, there could be breakage or protrusion, and there could be a bursa formation. So the cannulated screw fixation have been devised. These problems are overcome if the tension band wiring is done through the 2 cannulated screws as shown in this particular diagram instead of using 2 K-wires. Now these are the various methods of how the tension band wiring can be done. The first is the routine tension band wiring, second is use of the cannulated screws, and a tension band wiring using the cannulated screw. Now, when you use cannulated screw fixation, the advantages are early mobilization of the knee, less soft tissue reaction, the rigid stable fixation in the osteoporotic bone, and the lag effect of the screw provides a better compression. The destructive force is shared equally by the screws and the circlage wire, thereby reducing the chances of breakage. Now, this particular diagram shows the different ways of using tension band wiring technique and the circlage wiring and the cannulated screws. So depending upon the situation, you can use one of the methods. Sometimes you need to go for a patellectomy. Now this could be either a partial or a smaller distal or the proximal pole fracture, or complete for comminuted fractures. Now the emphasis is on now preserving as much patella as possible. The complications, post-operative complications, early fracture dehiscence, post-operative infection, and refracture 1 to 5%. These are the complications. Then avascular necrosis 25% in the proximal pole are some of the common post-operative complications. The delayed complication, this is like the knee stiffness, osteoarthritis of the patellofemoral and the knee joint extensor lag, etc. can also occur. Delayed union, non-union, loss of knee motion, etc. are other complications. The disadvantages of patellectomy, most important, the strength of the quadriceps, it returns slowly, although the knee motion is regained quite fast. Second, obvious atrophy of the quadriceps muscle persists for months and often permanently. If you do the patellectomy, these are the disadvantages. The third disadvantage is the protection to the knee offered by patella is lost. And the fourth disadvantage, pathological ossification may develop where the patella is excised. Now, what is this extensor lag? The extensor lag, this is the inability of the patient to perform the last 10 degrees of extension as shown in this particular picture. About 80% of the quadriceps strength is required to bring about the last 20 degree of extension. Please remember. After patellectomy, due to the decreased lever arm, the efficiency of quadriceps is reduced and the patient will be unable to bring about the terminal extension of the knee. That is what we call that patient has developed an extensor lag. Thus, an attempt is made to save as much of patella as possible, all of the patella or at least the proximal or distal half if the practical, to preserve the quadriceps efficiency. Now, there are certain disturbing facts. Do you know the common sequelae of the patellar fractures? One is patellofemoral arthritis, and second is instability of the knee joint. Third, decreased range of motion of the knee. And fourth, the difficulty with the stairs, downhill walking and kneeling. Now, there are recent advances. Arthroscopically assisted percutaneous screw fixation for the displaced patellar fracture is being tried with varied success as shown in this particular picture. Now, let us discuss on the injury to the extensor apparatus of the knee. The extensor apparatus of the knee is comprised of following 6 structures as shown in this particular picture. 1. The quadriceps muscle with a group of 6 extensor muscles and the quadriceps femoris tendon. 2. Patella. 3. Ligamentum patelli, that is patellofemoral and patellotibial ligaments. 4. The patellar bursae and the fat pads. 5. Capsule and the synovial membrane. The quadriceps muscle consists of rectus femoris, vastus medialis, vastus lateralis, vastus intermedius, articularis genu and ligamentum patelli. So the quadriceps strain, the causes includes direct blow to the muscle, and second cause indirect forces due to the violent sudden contraction. The sites include the rectus femoris is the most commonly injured muscle. This is followed by the vastus medialis, lateralis and intermedius. Now, avulsion may occur at the upper pole of the patella or the tibial tubercle and are rarely through the patella itself. As you can see here in this particular diagram, the first picture showing avulsion fracture at the upper pole of the patella, the second picture showing the avulsion at the distal end of the patella. Now, in the rectus femoris injury, the symptom wise, the patient complains of pain during the hip flexion and the knee extension, as this muscle is known to act on both the joints. Tenderness is present and at the site of the injury. In grade 3 sprain, a gap may be felt at the site of rupture and ambulation will become difficult. In injuries to the vastus medialis, intermedius or the lateralis, the patient may complain of pain and limp, terminal stage of flexion and restricted flexion is extremely painful. In general treatment, the grade 1 and grade 2 injuries can be managed conservatively, while the grade 3 injuries may sometimes require surgical suturing in the event of complete rupture and loss of function. So coming to the treatment methods, grade 1 and grade 2 strain, ice therapy and ice packs, compression bandage, that is Jones bandage can be given, and the limb elevation, the rest, ice, compression and elevation. Then once the pain subsides, the mild isometric exercises, then relaxed passive knee movements can be started. To improve the strength in the later weeks, the mobility of the knee joint, active and active assisted knee exercises are begun. Progressive resistive exercises to increase the endurance of the knee muscles are then further added. Gradual weight bearing with the assistive devices can be done. The patient should be functionally independent by 6 weeks. For the grade 3 strain, the quadriceps exercises are begun by 5 to 6 days. Self-assisted straight leg raising is advised. By second and third days, non-weight bearing and a partial weight bearing for about 3 weeks. Full weight bearing by 6 weeks. For the extensor leg, electrical stimulation helps. Rest of the measure is the same as mentioned above. Now coming to the acute patellar dislocation. The lateral dislocation of the patella, as you can see in this particular picture, they are very common and are due to the lateral forces acting on a semi-flexed knee. The patient complains of severe pain, swelling and inability to bend the knee. Patella is seen and felt on the lateral side. The treatment wise, close reduction and the above knee POP casting is done under general anesthesia. Immobilization in a long leg cast may be required for a period of 4 weeks. The acute dislocation of knee. Now this is a uncommon injury. Uncommon. In my whole career I have seen only 2 cases. And is due to the severe violence in road traffic accident or fall etc. It is usually associated with injuries to the collateral cruciates and the menisci. The patella may also be fractured and dislocated, and there may be, of course, the vascular injury. The popliteal artery may get injured. The treatment wise, conservative, an attempt must be made for the close reduction under general anesthesia, and above knee POP cast is applied for 12 weeks. Surgery, the open reduction may be required if the close reduction fails, or if there is extensive ligament injuries which may require repair, reconstruction or both. The knee is immobilized in above knee POP cast and for about 12 weeks. With this we end our discussion today. Thank you. Thank you very much for the patient listening. I hope you are visiting my YouTube channel regularly. Please, if not visited yet, visit it, subscribe it, share it. Please do it now. Thank you.